I've been treating vaccine injury for the last 4 years, for 3.5 years. I've been treating POTS and chronic fatigue syndrome and MCAS and histamine excess, and basically all the things that are associated with long COVID. And we have some questions already, so I'm going to start there. This question is asking, how would you know if one stellate ganglion block is enough, or do you need more? And how do you know they will last? Well, the only way I can answer this question is, why are you getting a stellate ganglion block in the first place? So the purpose of this is to temporarily disconnect the sympathetic nervous system between your brain and your body. So this happens at the stellate ganglion, which acts like a relay station to send signals both ways, to the brain and from the brain to the rest of the body. If you don't have dysautonomia, then the stellate ganglion block is probably not going to help. As far as if you need more or not, that's going to depend on how long you've had the dysautonomia. If you've been stuck in fight-flight for a long time, it may take several to get you out of it. That's just what I call the unlocking the door analogy. Once you get the door unlocked, then you need to keep the door open. So the way this works is the longer you've had the dysautonomia, the stronger the spring that wants to close the door becomes. So it takes more effort the longer you've had dysautonomia. As far as how long they will last, the block itself is very short. That's not what we're aiming for. It's the effect that it has long term is what we're after. And it can last indefinitely. But if you have not stabilized your autonomic nervous system, it can recur, and it can go back to where it remembers as the abnormal normal, so to speak. I hope that answers your question. Next question is, what do you think about using mestinon and low-dose naltrexone for treatment? And are there long-term risks to using both? So they serve different purposes. And I don't just recommend taking things from a roulette wheel, basically put all the treatments and supplements on a roulette wheel and just spin it and kind of see where it lands. I focus on the causes first. So go back to the mechanisms. What are you trying to treat? First off, what do you have? I don't know. So mestinon is a cholinergic type medication. Okay, so what it does is inhibits the acetylcholinesterase, which is an enzyme that breaks down acetylcholine. So what that does is that acetylcholine now accumulates. So this is really indicated for myasthenia gravis, which is a autoimmune condition where antibodies attack the receptors where acetylcholine binds, more so in muscle than anywhere else. But it can be used to increase your cholinergic tone or parasympathetic tone by taking this medication. Low-dose naltrexone works very differently, and this is meant for decreasing neuroinflammation mainly, and it does this by modulating the microglia, which are the immune cells inside your central nervous system. That's your brain and your spinal cord. It also has some effect on the immune system. So as far as long-term risks, really mestinon is the more risky medication compared to low-dose naltrexone, because it can increase the amount of acetylcholine there. And while a little bit is okay, if you overdo it, it can actually cause a cholinergic crisis, which will end you in the emergency room. So that's what I have to say about these two. Let me see here. Here's another question. So how many do I need? And I'm assuming this person is referring to stellate ganglion blocks if I had long COVID 4 years. The answer is I don't know. You need to see how you respond. You need to see which dominance you have, if it's right dominance, left dominance, or non-dominance. That will determine if you need both done or just one side done. And you need to see how you respond to it. That's really the best way I can answer to you or for you. I don't know how many you will need. Can I go back to my normal life after treatment, or do I need to still pace and be careful? If so, did the treatment work, and what should one do then? So, again, the pacing and being careful is more for mitochondrial dysfunction than for dysautonomia. However, there is a period of time after the block where where your autonomic nervous system is going to be fragile. So that means that we need to stabilize it and maintain it. And the best way to do that is with vagus nerve stimulation. Okay, and that's going to be a long-term treatment. It's not forever, but the point there is just to stabilize your autonomic nervous system so that it settles where we left it, not go back to where it was before. I hope that answers your question. Here's a question from Lisa. Well, you would have to be here in order to obtain the treatment. I mean, some treatments are done in person, and there's really no other way for me to be able to help you unless you're here. Yes, several trips, and a lot of people do it. Here's a question about cancers popping up after COVID vaccination. In my opinion, are the cancer risks limited in time? It has been years since the last booster. Is cancer risk low or not? So my feeling on this is not just limited to COVID vaccinations. It also can occur post-COVID. And because both of these alter the way your immune system functions, we call that immune system dysregulation. Yes, there's been some increased cancer risk. I don't know if it's long-term risk or not, but at least early on, we have seen some aggressive cancers pop up. I don't know if it's correlation or causation, though. I haven't seen any studies looking at that, but it sort of would make sense because, like I said, it alters the immune system function, and that is what patrols and controls any new cancers that pop up are typically taken care of by your immune system before you ever hear about them or see them. So one of the features of COVID is it infects some of the cells in your microbiome and your colon, and it tends to damage or destroy the bifidobacterium, which is one of the species in your gut. It also attacks other microbiome species, but that is a big one. And yes, you can replace it. So bifidobacterium tends to be in dairy products and fermented products, or you can just take probiotics that have bacteria species that contain bifidobacterium. So yes, it's possible to regrow. It's possible to repopulate your gut with bifidobacteria. And the other species that we're after are butyrate-producing species. Some of them are bifidobacteria, but there's others. And the reason we want to replace the butyrate producing bacteria is because not only is this short chain fatty acid used as food for the microbiome, it's also useful to stabilize the colon cells, and they use it for food too. And it also helps with the gut brain axis. It helps reduce the microglia activity. In other words, without butyrate, the brain can experience neuroinflammation. Hi, Christina. So Christian asks about his sister's daughter being on low-dose naltrexone, Abilify, and Oracea. Oracea? I'm not sure how to pronounce that one. Do you think this treatment approach makes sense, or is there anything else you would recommend? Okay, so let's be clear here. This is a public forum, and I can't make any personal recommendations, diagnoses, or treatment suggestions to you or your sister's daughter, but I'd be happy to do that through a consult, which you can obtain by contacting my office. But what I can tell you is that I don't know. And the reason I don't know is I don't know what her doctors that prescribe this are treating. So I don't start with symptoms. I start with causes and mechanisms. And the top three I look at are dysautonomia, which breaks up into fight or flight and vagus nerve dysfunction, and they are distinct, and they're both caused by COVID. And then you have the mitochondrial dysfunction, and then you have the gut dysbiosis. This is where the damage to the microbiome causes various symptoms. Now, those are the three primary mechanisms. Now, underneath, these three primary mechanisms cause secondary mechanisms. These primaries are caused by COVID or the vaccine themselves. And then these primaries cause the secondaries. And the secondaries would be things like endothelial dysfunction. It would be mast cell activation or histamine excess. It would be hormone imbalance. Okay? These are some of the main secondaries. There's many others, including neuroinflammation. And like I said, there's several others that occur as a secondary mechanism thanks to the primaries that were caused. Chronic inflammation is another secondary that causes many tertiary problems. So I would be happy to help your sister's daughter, but she would have to come in so I can diagnose her first, or at least do a telemedicine. So I can diagnose her first, and then we come up with a treatment, and then I can tell you if the treatments are appropriate or not. Okay? Sorry about that. By the way, we have a new group. It's a paid group. It's not on any social media. It's not on Facebook. It's not on Twitter. It's not on Reddit or any of the other social media things. I interact more frequently in this group, and we discuss things that really are not discussed anywhere else on the internet. If you're interested in joining, I'll put up a link for a waiting list. Let me do that now. Let me see here. How do I do that? Here we go. Okay. So yes, if you're interested, just put your name down and email address. It's $99 for the year. This is we're offering as founders joining right now. It's going to be significantly more after May 30th. Let me see here. There we go. I'm still learning this system. All right, so Becky asks, well, it's more of a statement about insurance. Would insurance cover your care? So really, medical insurance doesn't really recognize long COVID yet. Yes, there is a code for it, an ICD-10 code, but it doesn't really recognize the treatments that are available for long COVID. So there's also limitations for insurance that um, you wouldn't really be able to provide the care I want to provide if I relied on what insurance requires um, for general office visits and medical care. So that's really the main issue is I have to stay outside of insurance in order to provide the kind of care that patients deserve and need. And I wouldn't be able to do that if I accepted insurance for these. Here's a great question about anhedonia. So this is kind of an emotional dysregulation that occurs. It is part of chronic fatigue syndrome, or ME/CFS. It is also a part of long COVID. So this could be from neuroinflammation, or could be more on a higher level dysfunction rather than a specific mechanism. And yes, I do think it can resolve and go away. I have treated patients for anxiety. I've treated patients for depression. I've treated patients for PTSD. I have treated patients for depersonalization and derealization. So and anhedonia as well. So yes, it is treatable. It should resolve once you treat the initial mechanisms. Sure, Jennifer. You're welcome to sign up or sign your daughter up to the waiting list. As I said, we're still working through our list. A lot of people want to join, um, and we're really trying to get people in the group. But the point of the group again is going to be a very tight knit group of people who are very serious about getting better from long COVID. We're kind of filtering out all the noise and getting down to nitty gritty and dissecting down to the core of long COVID. My goal here is to get people better. Christian asks if there's any emerging treatments or clinical trials for severe post-COVID patients that look promising. Sure, there's many studies that are being conducted or being initiated, but I don't know yet if they're promising or not, because it takes a little bit of time before we see any data. So a lot of things we see are the ideas or the theory, what they're looking for, but until we see the data and the methods that they used to make sure that there weren't any biases in there, it's going to be difficult to really say if they look promising or not. But yes, there's a few interesting studies out there, but I hesitate to really say anything more about it until we see the data. Okay? Hokey Pokey asks, how would I treat reactivated Epstein-Barr virus? Well, first, I want to confirm that it's reactivated. And how would you know? Well, a lot of people are going to have antibodies just from earlier exposure, and that doesn't mean that it's reactivated. Epstein-Barr virus is part of the herpes family viruses, and what that means is that once it enters your body, it never leaves. It goes latent, it stays in your cells, but it usually doesn't cause a problem for most people. There are some triggers that can cause it to reactivate and go into a lytic state, where it's again reproducing and causing problems. But just having reactivated Epstein-Barr virus does not mean it's actually causing a problem. So first, I look to see if it's truly reactivated, and the easiest way to do that is to look for early antigen antibodies. Early antigen tends to be positive when the virus is active and tends to be negative when the virus is latent. Then I look to see if there's any problems being caused by the Epstein-Barr virus. So some people just get another case of mononucleosis. Some people get other complications, like it can involve your liver causing a hepatitis, or it can involve your brain, or it can even involve your bone marrow. But a lot of times it doesn't cause any problems. It's reactivated for a little while and it goes away, and um, you just happen to have tested it and found that it's reactivated, but it may not actually be causing a problem. But if I were to treat it, there are several antivirals that specifically target Epstein-Barr virus. There's also some off-label products that also help control Epstein-Barr reactivation to basically make it go latent. Okay? Lisa is asking, how do I know if a patient has inflammation? That's a great question. So there's two different kinds of inflammation. There's localized inflammation and there's body-wide inflammation. Both can be chronic, both can be acute. So if inflammation is contained to one organ or one area, it may not show up on blood work, for instance. It also depends on the level of inflammation. So you can look at things like C-reactive protein and some of the interleukins, interleukin 1, interleukin 6, can increase with acute inflammation. Chronic inflammation is a little harder to catch. You can look at ESR, you can look at ferritin as well. These are more nonspecific, but they may help locate that you have like a body-wide inflammation. You can also look at imaging to see if there's any areas that show areas of inflammation or edema. Okay? But there's no surefire way. Hi, John. I see you had 2 stellar ganglion blocks, and now you have more brain fog and lightheadedness than ever. So what I would recommend next is to be evaluated. Were you actually evaluated before you had a stellar ganglion block procedure? So the idea is to figure out what's going on first, and then, and only then, if you have dysautonomia, if you have fight or flight, if you have other symptoms of dysautonomia, then a stellar ganglion block makes sense. But if you had a stellar ganglion block because you showed up at the office and that's what the provider does and nothing else, then I mean, I really can't recommend anything else, because if you haven't been evaluated, if I haven't evaluated you, I really don't know what you would need to do next. But step one is always diagnosis. So you need to determine the mechanisms, and then you go from there. Here's a question by Alicia. And the question is how to determine if the symptoms are caused by COVID or the vaccine. Had vaccine, had vaccine, and one and only vaccine, and then had COVID a short time after. How do the treatments differ based on this? They really don't. From the clinical standpoint and practical standpoint, separating the symptoms or what actually caused your symptoms is not going to be really all that important. Whether it was COVID or the vaccine, the treatments are relatively the same for both vaccine and long COVID. And that is targeting the mechanisms, determining what mechanisms you have going on, the causes, and then treating them. Okay? Christian is asking, what is the most important thing a parent should focus on when their child is stuck in fight or flight? So, fight or flight is a nasty state to be in. Now, it does have a evolutionary purpose. It is meant to protect us from harm. It is a survival mechanism. Every creature alive has a survival mechanism that is a fight or flight type mode, as you call it. And the problem with this mechanism is it's great when you actually need it. If you're fighting for your life and you need to make a decision between fighting and running or hiding. And the problem is when you're stuck in fight or flight for long periods of time, it's like running a car and that has a turbo boost mode in it, or turbo mode, and instead of just accessing it once in a while when you need it, it's on all the time. The problem with this is it wears you out. The things that your brain needs to do and your body needs to do during fight or flight are very different than the rest of the time. The biggest problem with this is that the brain flow changes in your brain, okay, and in the rest of your body. And if you're stuck in survival mode, all of your resources are being focused on survival, not on digestion, not on repair and healing, not on replacing damaged tissue. So you don't sleep well because you're on alert, your body's on alert, and you don't digest well. And there's other issues with fight or flight. So the most important thing is getting it diagnosed properly by somebody who understands long COVID and dysautonomia, and then doing a treatment for it to get your child out of a constant fight or flight. So I'm just looking through the questions, if you give me a minute. Donna asks if she had COVID, I guess in February of this year, and influenza, and it reactivated everything. As if she was pulled back in time. Yeah, unfortunately, that can't happen, and doesn't have to be COVID. It could be any virus, any respiratory virus. It can cause the loss of taste and smell again. That is because if you haven't stabilized your autonomic nervous system, it appears that it's repaired, but it really isn't. It's just compensated. And any virus, any stressor, any surgery, any anesthetic can potentially pull you back to the prior autonomic nervous system state, even though it's not COVID that got you back. In other words, the damage has been done by COVID. It could be done by other viruses too, but any other virus can then cause basically going back to where the damage shows itself. Christian asks about stellar ganglion blocks, and yes, I do them differently. I can't answer about making sense of doing them somewhere else. I can only speak about myself and what I do, and the successes that I see based on how I do it. I mean, that's really the best way I can answer this, Christian, because I have no idea how the docs perform them, or what else is involved. But with me, the thing is I don't just drive the needle. I'm also doing the diagnostics and the testing and the information way beforehand, and to see if you're even a candidate first before before doing the procedure. So I do comprehensive care for long COVID, not just do stellar ganglion blocks. Christina asks if you've been sick, if she's been sick, I guess since 2020, is there any hope for them, for her and her husband? Talks about mold and that they're both fighters. So I don't really consider mold or parasites as part of long COVID. I know those are big things in functional medicine, but I don't believe that they're really involved at all in long COVID. Yes, there's hope. There's always hope. So dysautonomia, as I said, tends to become more resistant over time. So it just requires more treatments to get that door open and then keep it open. But yes, it's still doable. It's still possible. COVID really does damage your body. It damages parts of your nervous system. It damages different organs. It's a nasty virus. It really is. 2020 would have been either the Alpha or the Delta variant. Those were more nasty than the Omicron that we're having now. But yes, there's still hope, and there's still possibility, a lot of possibility for recovery. But again, you got to target the root causes, the mechanisms first, because if you're just treating the symptoms, you're not going to get anywhere. There's just so many symptoms part of long COVID. It's a never ending. It's really never ending. Hoki asks about spike protein levels going up. So I want to confirm something. Are we talking about spike protein antigen, or are we talking about spike protein antibody? So those are two different things. So most labs will test for the spike protein antibody, not the antigen. Yes, you can get an antigen test, but it's not widely available. So something is stimulating. I'm assuming it's going to be the antibody unless you tell me otherwise. But something is stimulating antibody production to the spike protein. That means that it's either being produced somewhere or it's still present in your body causing the antibody production. There really isn't any supplement or medication that would get rid of it per se. Okay. Technically speaking, you can get rid of any autoantibody or antibody by using something like plasmapheresis, but there's no medication or supplement that would help. Okay. Donna asks if there's any way to treat that. What is that? I'm not sure what that is. Eventually go back to baseline. All right, you would really need to explain to me what that is, because I don't remember what you're referring to. Sorry. What do I think about the white clots that a couple of doctors are talking about on a few YouTube videos? They're saying they think they're growing in some vaccinated people. They also say that imaging won't find these so-called embalmer's clots. Hang on here. There's more to this. It's okay. Yes. Okay. Um, I'm not sure about white clots. I'm not sure if you're talking about microclots. Um, COVID can cause endothelial dysfunction, and there is a period during COVID and early on in long COVID where there's a hypercoagulable state. That means that you're more likely to form clots due to the dysregulation of the immune system. Okay, platelets tend to be hyperactivated, which make them sticky, and they're more likely to form clots if there's damage to the endothelium, and endothelium is a lining of inside of blood vessels. Now, microclots in particular refer to capillary beds, really small blood vessels. Microclots are microscopic by nature. They're not actual true clots. They're denser. They're a combination of an amyloid protein together with fibrin, and they are resistant to the normal mechanisms that our body uses for breakdown of clots. And make no mistake, we have to be able to break the clots down that we form, because after the repair, after there was damage to a blood vessel and the clot stopped the bleeding, you have to be able to dissolve the clot after the repair is complete. And we form clots all the time. We don't think about it or know about it because they don't bother us. They form from little injuries that happen around our body, and our clotting system goes into effect and clots them off, and then repairs the damage and removes the clot. That's what's supposed to happen. So as far as clots in general, as I said, there's an early period of time when there's a hypercoagulable state. That's during COVID itself. And early on in long COVID, it tends to resolve as long COVID progresses. So I'm not sure what you're meaning about these white clots. I haven't seen the videos that you're referencing or the embalmer's clots, but so I'm not sure what else I can say about this. Sorry. What are my thoughts on augmented NAC? My understanding is that it helps destroy any spike left over in the system that might be causing inflammation. Have you used it in your practice? My thoughts are it's a gimmick. NAC is NAC, N-acetylcysteine. I looked at the website. I don't really see any methods how it's actually augmented. We're talking about an analog of cysteine, which is an amino acid. It absorbs fairly well, even not augmented. So to me, it really seems like a marketing gimmick more than anything, to be able to charge 3 to 4 to 5 times what regular NAC costs. So, and it really has no ability to attack spike protein. It has no protease function. It has no enzymatic function. Okay, so I don't know where the idea that NAC can destroy or remove spike protein, or any protein for that matter, would come from. If I can ask you guys to keep the questions shorter, because it's really hard to display and actually read through the longer ones. So I'm going to be skipping anything longer than like 4 or 5 lines. Alicia asks about can certain patients benefit from LDN, low dose naltrexone? it is being widely prescribed. Doctors are also grasping at straws. A lot of the things that are being prescribed for long COVID come from what we know from chronic fatigue syndrome. So that's where the low dose naltrexone comes from. That's where the low dose Abilify comes from. And that's really where Mestinon comes from as well. So yes, there's a benefit from low dose naltrexone. As I said, it helps modulate the microglia in your brain and in your spinal cord. So that helps reduce neuroinflammation. Okay. And it also helps stabilize your immune system. Now, remember, COVID destabilizes and causes dysregulation in your immune system. So what that means is it doesn't suppress your immune system, and it doesn't make your immune system overactive. It just controls the swing of it. It basically removes the limits to the swing of the pendulum. So normally there's a limit to how low your immune system would go or how high it would go, but long COVID removes those limits, and now the pendulum swings kind of to both sides. So you can have issues with immune compromise in some days, and in some days it's overactive and you're having inflammation and autoimmune conditions pop up. So it helps with that, but it's not to be used just indiscriminately. It's relatively harmless, but there are some side effects that you need to be aware of. But my point is I don't just prescribe a medication out of the blue or just for no reason. It has to be connected to one of the mechanisms that I'm treating. Okay? So Erica is asking about causes and not symptoms. So which are the most common causes? So what I'm talking about here is COVID directly causes the primary mechanisms or primary causes. And that's the virus, the SARS-CoV-2 virus. So number one is dysautonomia, and it can either cause a fight or flight type dysautonomia, or it can cause a vagus nerve type dysfunction, dysautonomia. The second one is mitochondrial dysfunction. That has to do with COVID basically damaging the mitochondrial DNA and the structure of the mitochondria inside your cells. Okay? And the last one is the gut dysbiosis, and that's COVID going in and damaging both the lining of your colon because it has ACE2 receptors. It infects those cells, and the microbiome. And it tends to target certain species of the microbiome. By altering the microbiome, it causes alteration in the gut-brain axis. Okay, it causes a leaky gut situation. And while you would think that would be just limited to the gut, it's not. A lot of things that come from the gut help regulate your immune system and help keep the inflammation in your brain down. Okay? Rapamycin, low dose of rapamycin, I would use in the mitochondrial protocol. I would use it sporadically or intermittently as part of the mitophagy biogenesis part of the mitochondrial protocol. It wouldn't be the first thing I would go to. I would start with supplements first, and only if needed, I would introduce the rapamycin. Even low dose, there's potential for side effects. So it's not first line for me, but it could be second or third line. So Esther asks about the mitochondrial regime. So when I originally designed this, it was 4 steps. And the 4 steps were antioxidant, step 1. Step 2 was the mitophagy. Step 3 was the biogenesis. And step 4 was the mitochondrial support. But what I realized doing this over a course of close to a year is that a lot of these can be combined. So what I've done is I've combined step 1 and step 4 together. So now step 1 is the antioxidants plus the support, the mitochondrial support. And what do I mean by support? I mean things that make the mitochondria job easier. Okay, so basically make the function of the mitochondria easier, plus things that make the mitochondria construction easier. So during the biogenesis phase, we're making new mitochondria. So anything that we can make it easier for the structure of the mitochondria to be basically pre-built, parts of it would make it easier for your body to make more. So two things happen, okay? Either all of the mitochondria are damaged inside a cell, in which case there's no hope for this cell. That cell needs to be destroyed, and we need to destroy it in a non-inflammatory way, okay? So and the reason for that is if it's destroyed and it causes inflammation, that causes additional oxidative stress, okay? And it can also damage surrounding tissue. And the second thing is if a cell has some working mitochondria, then we should be able to use those to make new ones with the right signals and destroy the damaged ones, called mitophagy. And what we're after here is complete mitophagy. And what I mean by this is that every component, every part of the mitochondria is broken down. Okay, if you have incomplete mitophagy, the mitochondrial contents will spill into the cytoplasm of the cell. And that can also trigger an inflammatory reaction. So the way I split up the regime, as you say, is step one is focusing on every day, okay, for at least 90 days. Some people need 180 days. And what I focus in step one is going to be the antioxidants and the supports for mitochondrial creation and for mitochondrial function. Step two is intermittent. So I start that off at 7 days only out of the month. And the goal there is to kill off damaged mitochondria or do autophagy, depending on what you have going on, and create new mitochondria. So the reason it's sporadic and you want to keep this slow and short, is because we want to limit how much mitophagy is going on to avoid the incomplete mitophagy. So if you feel bad during step two, that means you're probably doing too much mitophagy. We need to cut back. And once you get into the right groove, in other words, the supplements or the medications do not cause you to feel bad during step two, then I do it every other week. And I've seen some big turnarounds with this system. And there are differences for each person depending on their needs, for which supplements I choose and things like that. Hopefully that answers your question. So questions about cost is best answered by my staff. I actually have no idea on the costs. I really focus strictly on the medicine, and everything I do, I compartmentalize that. Okay. Hang on, I'm having some issues here. There we go. Okay, so this question is about MCAS and long COVID. Yes, they are related. Long COVID can cause not just MCAS, but also histamine excess. And the reason this happens is, well, we're talking about the primary mechanisms. When COVID damages the microbiome, there's an opportunity now for certain other species to overgrow or move in. And sometimes histamine producing species move in. And what they're doing is they're taking the regular food that we eat and converting some into histamine. So there's an amino acid called histidine that some bacteria in your gut can use to make histamine from. They're not trying to be harmful. It's just part of their normal metabolic process. As far as MCAS, we're talking about the stability of mast cells. So there's a few things that mast cells need to remain stable. One is ATP, and they need a considerable amount of ATP, which is our energy currency of cells, to remain stable and not discharge. So if there's a mitochondrial dysfunction, for instance, and it happens to involve mast cells, that's one reason that mast cells could inappropriately degranulate. Another reason is if there's a chronic state of inflammation. Mast cells tend to want to degranulate. And lastly, the histamine we talked about that being generated in the gut, the presence of histamine actually can cause mast cells to degranulate as well. So there's a lot of different interactions between all of the mechanisms, including dysautonomia. So when you're in fight or flight, your sympathetic nervous system is overdriven, and that can cause mast cell degranulation because it doesn't just get your nervous system excited, it makes your immune system excited too. So basically, all the primaries can potentially cause MCAS and or histamine excess in some way, and all of them are related to long COVID. Caitlin is asking about if I evaluate and treat for cervical instability. Yes, I do. It's not technically part of long COVID, but I do evaluate it. Can long COVID worsen neck cervical pain? Yes. First, we have the classic coat hanger pain, which is the pain that starts kind of in the middle of your face where your nose is. That would be the hook, and the rest of the hanger would go down your neck and into your shoulders. So basically, the top and partly the sides and back and front of your shoulders would come into this coat hanger pain. Muscle stiffness, okay, that has causes from several of the primary mechanisms. Okay, pain can come from myalgia, which is inflammation in the muscle, or it can come from arthralgia, which is inflammation of the joint, or it can be from the connective tissue itself. So you don't have to have cervical instability to have neck and shoulder and basically coat hanger pain. That's not required. So pain is a very big part of long COVID, unfortunately, and a lot of it is being driven by the inflammation. Okay. Heather is asking, why would I have low neutrophils since COVID? So I mean, I wouldn't know, Heather. It could be that perhaps Epstein-Barr or CMV virus can be involving your bone marrow potentially. Without knowing what the rest of the CBC looks like, I don't know. But typically, it doesn't. COVID or long COVID does not alter the white count significantly. Angela asks what my thought on hyperbaric oxygen therapy. So early on, I really hated hyperbaric oxygen therapy because of the oxidant effect. So when we're looking at mitochondria here, if you're in a context of mitochondrial dysfunction, having extra oxidants is the worst thing to do. Okay? The point of hyperbaric oxygen therapy, normally what it's indicated for are things like resolving bends. If you have bubbles from a deep dive and you ascended too quickly, if you have carbon monoxide poisoning, if you have a wound that won't heal even with antibiotics. The last one, the wound, is often due to ischemia because there's vascular disease and there's not enough blood and oxygen getting to the infected area. So I do see a role of hyperbaric oxygen therapy, but you have to be careful, okay? In the context of mitochondrial dysfunction, you have to be careful. If you didn't have that, if you're just doing it for other reasons, that's fine. Your body has enough antioxidants, internal antioxidants, to neutralize any oxidative damage, even though it's temporary. However, if you have mitochondrial dysfunction as one of the mechanisms in long COVID, and a lot of people do, more than 70% of people have mitochondrial dysfunction in long COVID, it could be dangerous. So creating additional oxidative stress will cause more damage and will damage your mitochondria more. So where do I see hyperbaric oxygen therapy? Well, as I said, it's ischemia. So if you have endothelial dysfunction, if you're having areas that are not getting enough oxygen, then hyperbaric oxygen therapy makes sense. It may help dissolve some clots. There's some studies showing that, but main reason is to increase the oxygen content of your blood, so that even if little oxygen is getting in, a little blood is getting into an area, it will still receive more oxygen than it would normally. However, what I would recommend with hyperbaric oxygen therapy is keeping the sessions short and keeping them infrequent. Okay? If you're going to do it, take antioxidants beforehand, before the treatment, because your body doesn't produce enough to neutralize any oxidative damage. Okay? So, I mean, yes, I think there is a use for it. You just have to be careful. It is a double-edged sword. And ischemia in itself can cause oxidative stress, so that's not good either. But my question is would just regular oxygen fill the bill, or does it have to be hyperbaric? Okay, which means that it's high pressure and 100% oxygen on top of that. So yes, it's okay in some instances with some care. So Manuela is asking about if this does this to cells could also cause develop ALS. So ALS, Lou Gehrig's disease, right, is an autoimmune condition that damages specifically the central nervous system. Okay, and mitochondrial dysfunction has been implicated in ALS, and it is limited to the central nervous system, though. So long COVID does not cause ALS or any component of ALS. Some people have developed Guillain-Barré syndrome more often after vaccination, but that's not really something unique to COVID vaccines. That can happen with any vaccination, really, but not ALS. Christian asks if there's any factors that increase a person's risk developing post-COVID. Yes. Yes, there's several things. Basically, having pre-existing damage or injury to any of the primary mechanisms that I mentioned puts you at risk for developing COVID. The biggest one is going to be the ANS, the autonomic nervous system. It doesn't mean you had to have had POTS or symptoms of POTS. There could be subclinical damage that you're not even aware of. And because the damage is already there, when COVID comes in, it adds its damage to it, and then you have a full presentation of long COVID. I do think if you have some mitochondrial damage or issues with the microbiome, that also puts you at risk for long COVID. Mama Hummingbird asks, can we use our insurance for the blood work you recommend when consulting with you? Sure. I don't have anything to do with the lab. We just send the orders in to the lab, and if the lab accepts your insurance, I don't see why you wouldn't be able to. I mean, we have many people who use insurance for the blood work. Alexander asks to discuss the E-therapy. So that's epipharyngeal abrasive therapy. So this is a procedure that was developed in Japan in the early 1970s, and some people even say late 1960s, as an answer to treat chronic epipharyngitis. Now, there is no such thing as the epipharynx, okay? There's no anatomical structure called the epipharynx. It was coined to describe the area that involves part of the nasopharynx. This is the back of your nose. We're talking about straight back, okay? And when we're talking about straight back, I'm talking about 3.5 to 4 centimeters, okay? I'm sorry, inches. 3.5 to 4 inches in the back of your nose. And the area involves the nasopharynx and a little part of the oropharynx, okay? So you have a tissue there called the mucosa, which is similar to the lining inside your cheeks. And some people have a structure called adenoids, which is very similar to your tonsils. It's a immune system structure that has a lymphoid tissue, which are cells that have white blood cells in them. And it generates IgA, it generates different cytokines, and there's many white blood cells in there. Now, technically, the adenoids are supposed to regress and kind of go down after teenhood, but in some people, it's still maintained. And the mucosa can be covered by either biofilm or thick layers of mucus that hide different remnants back there, including cytokines, including bacterial or viral components that don't really wash off. So a lot of people say, well, why don't I just do a neti pot? Just rinse out my nose. It doesn't reach the back of the nose, okay? That area does not get cleaned out when you do the neti pot. The sinuses do, the turbinates do, but not the back of your nose. All right. So the way this procedure works is the abrasion part or the rubbing part. Okay. So the idea here is yes, I use zinc chloride on the cotton swab, but really it's the rubbing part that does the work. And I am physically rubbing off the biofilms and the mucus and everything else off of your mucosa. Okay. And that is part of the treatment part of the therapy, and it does take several treatments to get results. Okay, you're not going to get it from 1 or 2. I've seen some people get it at 3 or 4, but what I target with this is head, face, neck issues. Yes, it does stimulate the vagus nerve in a very unique way. So if you're having issues with your voice or trouble swallowing, it may help. But I also treat head pressure and face pressure and fullness in the ears or tinnitus. Anything with eustachian tube dysfunction tends to get better. Postnasal drip. Things that are being caused from the back of your nose. Okay? I hope that helps. It's a quick procedure, but there's a lot of technical stuff involved in performing it. Last thing I'm going to say is how I do it. It's done using a very thin, flexible fiber optic scope. The one I use is 2.8 millimeters. Most ENTs have a 5.5 millimeter scope, just to give you a rough comparison. And as I said, I go in with a metal probe to rub the back of your nose, and it's coated in cotton. Esther is asking about SGB in another country. Any advice to doctor performing procedures? I mean, we all get taught the same way how to do it, okay? Just about. I mean, there's a standard technique to it. Now, what I've done is, because I've done thousands and thousands of them, I've developed a newer, better way of doing it. It just naturally evolved over a course of time because I was doing so many of them that my technique changed. So I can't really give advice on how to do the procedure. Each person is slightly different. There's anatomic variation of where the medication needs to be placed. But what I do is not a standard stellate ganglion block. That's why I call that a stellate ganglion procedure instead of an SGB. All right, and this will be our last question because I didn't realize it was after 11 o'clock. But Esther is asking, is there any test for mitochondrial function? Yes, there's several tests, but none of them are direct tests. So in other words, we are getting clues about the function of the mitochondria, but it's not directly from their function. So one thing I look at is the oath test. It's a urine test, and that looks at metabolites, organic acid metabolites from the Krebs cycle. So if there's a backup in one of those, there could be a problem with mitochondrial function. I also look at lactate and pyruvate. So if the ratio is altered or your lactate is a little bit higher in the range, there could be a sign of mitochondrial dysfunction. There's other tests you can try. I don't know for sure the validity of them, but I've tried them a few times. There's a mitoswab test that looks at you rub the cheek, inside of the cheek. It's called a buccal sample, and you can look at electron transport chain function, at least from there. So that's another part of the mitochondrial mechanism for generating ATP. So there's a couple of different ways to look at it. You can always do a muscle biopsy, but that's more invasive. So these all give us clues to mitochondrial function, plus the symptoms that come along, like post-exertional malaise is almost exclusively mitochondrial. And you kind of put it together and you treat the mitochondria, okay? Thank you so much, guys, for attending today. I hope it was useful. Again, if you want to get on the list to join our new paid group, I'm going to show it to you guys one more time. You can go here and just put your name in and your email. The cost is $99 for the year, and this is just until May 30th. The price will increase after that. And I discuss a lot of the stuff that we talked about here inside the group. Okay, we also go over things that questions people have that have not been addressed really anywhere else. All right, so if you'd like, this is where you go, and I'll see you next time. I'll try to do next Sunday at 3 p.m. or a little later so that people in Europe can also join in. Thanks.